going to kick off. We're going to be finished in time to hear the amazing story of the guys that rode across the Atlantic. Is Dr. Ruparel here? Yes, there she is. Do you want to come and sit on the stage? We haven't met before, but I know your talk's going to be brilliant. I'm Roger Kirby, and I'm the chairman of this session. And we're very lucky. We have a brilliant faculty here. We have my buddy Cuddy Carson from North Carolina, my brother Mike Kirby, and we have Dr. Mamta Ruparel, who's just arriving on the stage right now. So my job is to set the scene and tell you about the trouble with men. And as the audience, mainly male audience in here today will know, men are actually a mobile disaster area. They are their own worst enemies. And really the thesis of this 1 hour is to persuade you that urologists have an important role as custodians of men's health. We can encourage earlier presentation. We can counter this concept of toxic masculinity. And by doing that, we can help reduce premature deaths. Well, it's been known for some time that men's life expectancy is about 5 years less than women, all ages, and there are different reasons for that. It was originally thought that it was something intrinsic to men, that they naturally died 5 years before their female partner, but it turns out that quite a few of these things are actually avoidable, and we're talking now today for the next hour about how to avoid these issues. So what is the trouble with men? Well, they're risk takers, especially young men. They're more susceptible to cardiovascular disease. They have a higher mortality for most cancers, obviously prostate cancer. They drink alcohol more heavily than women. They smoke more cigarettes for longer than women, and Mamta will be telling us about that. They're subject to depression and other mental health issues. They're more susceptible to AIDS and die more frequently from AIDS. And many men have unhealthy lifestyles, lack of exercise, and a poor diet. 3 out of every 4 suicides are male suicides. Women often attempt suicide, but they often fail. Men, if they attempt suicide, they're more likely to succeed. I guess that comes back to sort of risk-taking behavior. Well, this is a slide of a blood cell infected by the AIDS virus, and it makes the point pictorially that men are more susceptible to this disease, especially in sub-Saharan Africa. And of course, the culprit behind these men's health issues is this molecule, testosterone, which results in a number of issues. You know, males tend to have problems with dominance and with aggression. The two are linked together. They repress their emotions. It's been shown that men who are concerned about their manliness are about half as likely to seek preventive health care compared with those who are concerned. Men often deny their own feelings, and in doing that, they deny those of others with, not surprising, resultant relationship issues. This is the kind of typical male. I put that up as a plug to my daughter's next movie. You'll be able to catch that on your screens on the 2nd of August. The Rock there is kind of typical macho man. You'll see him leaping out of aeroplanes and so on the 2nd of August. So, you know, the attitudes of men can be encapsulated by a constellation of Ds. They're in denial, so that results in delayed diagnosis. They subject themselves to danger. They have a rubbish diet, particularly red meat and carbs, as Julian Shah demonstrated when I had lunch with him half an hour ago. They drink, and when they drink, they are subject to violence, accidents, as well as liver disease. They take drugs, they become depressed, and eventually all of these things are compounded and encapsulated in a very expensive divorce, as illustrated by quite a few of my colleagues. So, you know, men are obsessed with sex, as everybody knows. You'll see from this video.
I think the organisers have done a brilliant job tonight, getting so many people from all sides of the business to attend. I think it's important for the purchasers and suppliers to meet face to face so they can make the personal bond.
No, I'm not at all interested in anything you've got to say, I'm afraid. I'm a very important man. Now, you are a very attractive young lady, and it's nice to have you here for decorative purposes. But you're not very important, so I can't be bothered to talk to you. Do you see? Unless, of course, your father or husband is important, in which case I would be prepared to patronize you for a few minutes for the sake of your important connections.
Right. Well, I'm not married, and my father's unemployed.
Well, there you are, you see. You're a very attractive waste of time. Oh, unless, of course, you want to sleep with me. I am a very important man, so it would be...
So, yeah, I think that, unfortunately, he's standing for Prime Minister right now. And he does typify some of the aspects of male health problems. So why do men seek healthcare? You know, the three principal reasons: they have trouble with their lower urinary tract, LUTs, they have anxieties about prostate cancer, often hyped up by outfits like Prostate Cancer UK or Tough, and they complain of bothersome sexual dysfunction, which not infrequently is associated with BPH.
Mr. Griffin, I'm just going to need you to drop your pants and we'll check your prostate. What? Drop your pants, turn around, and lean forward.
Okay. So how's this work? You just feel my pulse? Or... What the hell was that?
Mr. Griffin, that's a prostate exam.
Shut up! You had your finger in my ass!
That's how a prostate exam is performed.
So, yeah, men not only are reluctant to present for all sorts of reasons, issues related to sexual function, but they're keen to avoid clinical examination. So just taking up some of these issues, I was relieved to see this paper published in the New England Journal of Medicine, having had prostate problems sorted for me 5 years ago, that early prostate diagnosis can result in increased lifespan. Some of our colleagues are not so lucky. Poor John Anderson developed prostate cancer, developed metastases. He was the best president of BAUS that we never had because he got poorly just before he was able to take up his post, having been voted for it. And this is Peter Remington, another example of how rubbish men are at looking after themselves. He came cycling with us in South Africa and didn't take any notice of his blood pressure, his cholesterol level, ended up having a myocardial infarction and a stent in his left anterior descending branch. He was really lucky to survive thanks to coronary care in Eastbourne. So cardiovascular deaths, you'll be hearing more from my brother Mike about that. They actually are higher risk to men than cancer deaths, as you can see on the total number there. The risk factors for coronary artery disease are similar to those for erectile dysfunction. So clearly urologists need to understand the links between erectile dysfunction and cardiovascular disease. And again, we'll be hearing about those in more detail. In fact, diagnosing coronary artery disease isn't that difficult. It's controversial, but you can see the plaque there sitting on the left anterior descending branch of some unfortunate patient. And you can see the calcium deposited there. So the use of a coronary artery calcium score, a CT scan that only takes about 10 minutes to do, can be quite a reasonably accurate screening test for coronary artery disease. And it's something that urologists need to think about. A very good NPV, as you can see there. And if the score is very high, then they should be offered either a CT or possibly an invasive angiography. And intervention at that stage, that early stage, before the precipitating angina and myocardial infarction occurs, obviously has some benefit, and it's something that we should be discussing with our patients. There's an issue with red meat. You know, red meat is associated with manliness. Real men eat red meat, but it's been shown that 70 grams, that's 2 rashers of bacon per day, increases your carcinoma colon risk. Red meat's linked to global warming, water depletion, deforestation, and animal cruelty issues. So cutting back on red meat would be some good advice, because none of us wants to get a colon cancer illustrated there. Again, something we could discuss, something that I used to discuss with my patients, the possibility of having a CT colonoscopy, a virtual colonoscopy, which is much preferred to a regular colonoscopy and much better tolerated by patients. So this is Michelangelo's David from the Renaissance. This, unfortunately, is a current Michelangelo, too much of American fast foods there. No insult intended to Cully Carson from America. But the risk of too much fast food is this hazardous waste, as you can see there, and we'll be hearing from Mike about lifestyle, about the pathogenic cycle from inflammatory cytokines and leptins producing these cardiovascular risks. So I remember very clearly sitting in a restaurant in Wimbledon with Cully, drinking red Italian wine, rather nice wine, and we came up with this mnemonic of getting to a better place. Portion control, lose the booze, axe the snacks, cut the carbs, and exercise every day, and avoid eating hamburgers like that. And I actually hand out that leaflet to my patients, telling them they need to get to a better place and they need to eat a much healthier diet like this one of pulses and green vegetables, etc. And then another issue is alcoholic liver disease. The red graph there is the increase in alcoholic liver disease deaths over the decades. You know, there's no question that men, perhaps even especially urologists, drink more than is healthy, and cutting back on alcohol has got to be a good thing. Doing more exercise, you might recognize some of these cyclists in front of the Angkor Wat temple in Cambodia, cycling for tough, but getting men to do more exercise, encouraging them to live a healthier lifestyle is clearly something we should do, because there's no doubt that physical inactivity is linked to cardiovascular risk, and you can see the stats there behind that. So when patients present with erectile dysfunction or indeed LUTs, we need to think about all these issues that Mike will go into in more detail. The tip of the iceberg, this is one of Mike's slides. And we need to think ED doesn't just stand for erectile dysfunction, early detection, education, endothelial dysfunction, and possibly early death. That was Graham Jackson came up with that rather nice slide illustrating the problem. So urologist as a men's health doctor, you know, what we should at least consider is checking the waist, measuring BMI, pulse, lipids, hemoglobin A1C, blood sugar, testosterone, talking about smoking, talking about lifestyle, and discussing both CT calligraphy and calcium scores. So detoxifying men, just listed there, getting to a better place, knowing your numbers, cutting back on red meat, and I saw that binge responsibly on somebody's t-shirt the other day, which I thought encapsulated some things. And that's just a plug for the journal that comes out bi-monthly, and a lot of you hopefully will read. We're always looking for contributions to blogs and to the article itself. So I will hand on now to Dr. Carson, specially imported from North Carolina, to tell us a little bit more. Thank you, Cully.
Thanks, Roger, and thanks for the invitation to come talk about testosterone and cardiovascular disease. I'm obviously not a cardiologist, but I will give you my best urologic review of cardiovascular disease with regard to testosterone. It's a huge issue in the United States, as you'll see in a moment, because there's a class action suit, product liability suit about testosterone and cardiovascular disease generated by some questionable research. So these are my disclosures. Male hypogonadism, I think we need to define our terms, is a disorder associated with decreased testosterone and or sperm production, and it has signs and symptoms. So it's not only the blood test, but it's also the signs and symptoms of androgen deficiency, and it's caused by testicular defects, which is defined as primary hypogonadism, or secondary hypogonadism, which is hypothalamic pituitary defects as well. And often it's combined, and it may be associated with but not caused by age, and it may be also caused by sickle cell disease or a variety of other conditions, but clearly it's a common problem. The public perception of testosterone, as Roger said, basically is the macho man, the aggressive, athletic, svelte man, but more often it's this man who has a decrease in testosterone with so-called menopause, where the testosterone is decreasing with age, and so are his symptoms increasing with that loss of testosterone. And this is what happened in the U.S. As soon as these questionable studies were published, not only we as physicians read these studies, but the lawyers read them as well. So as a result of that, there were 2,000 cases in the United States, legal cases against testosterone manufacturing companies for testosterone and associated cardiac disease. I was involved with some of that. Most of those patients had multiple risk factors, and really the testosterone was a minimal issue in their cases. So what do we know about testosterone deficiency and cardiac disease? Well, this is a very nice table that was put together in the Mayo Clinic proceedings about a year ago, and it shows some of the things that testosterone do to support the healthy male. It's a support of lean body mass, of bone density. There's an increase in adiposity, decrease in energy with testosterone deficiency, and a decrease in physical and sexual, obviously. Sexual function is what we think about, but there are many other things. Metabolically, you can see some of the changes that can occur as a result of testosterone deficiency, and there are associated conditions such as myocardial infarction, sepsis, and trauma that occur more commonly in men with decreased testosterone, as well as diabetes. Insulin sensitivity is dependent on testosterone levels. Renal failure, malignancy, hypertension, and hyperlipidemia all have an impact or are impacted by testosterone deficiency. And the final pathway is atherosclerosis, coronary artery disease, and cardiovascular events. So clearly, testosterone deficiency has a major impact, not only on the man and his sexual function, but his life in general. So why the controversy? Well, there are two trials that were published several years ago that suggested that testosterone replacement therapy may increase the risk of heart disease or stroke. They were poorly designed and conflicted with other studies that showed that testosterone replacement therapy, and indeed normal levels of endogenous testosterone, were associated with better men's health. So the FDA, the Food and Drug Administration in the United States, convened a panel, which I was present for, and decided that because of these two poorly done studies, that they would add to the package insert a warning, a black box warning for testosterone replacement therapy and cardiovascular disease, and that stimulated all of the product liability issues that we're facing now. So this is one of those studies, the vegan study, 2013, where they looked at over 8,000 men with testosterones of less than 300. The endpoints were all-cause mortality, MI, or stroke. These are men that were on testosterone replacement therapy, and they had an adjusted hazard ratio of 1.29, which showed some increase in risk for those patients getting testosterone replacement therapy. Contrast that with another study by Molly Shores out on the West Coast, and indeed the populations of the two studies were very similar. They were veterans. Over 1,000 patients with testosterones, this time of less than 250 nanograms per deciliter. In her study, all-cause mortality was an age-adjusted hazard ratio of 0.61, which is a decrease in hazard ratio, showing that there was a benefit in her group of patients for testosterone replacement therapy. Another study, Finkel and colleagues looked at 55,000 men, and this was a very poorly done study that really didn't look at the patients in detail. It just kind of looked at a population group. These are men that were 65 years or older, receiving testosterone replacement therapy with a relative hazard ratio of 2.2 in those men over 65, 2.9 in those men under 65 if they were taking testosterone replacement therapy. Contrast that with this study by Ballergan, a very similar study again that used the same kind of technology and a population-based study, but what they showed was there was a reduced hazard ratio of cardiac events, cardiac death, and cardiac adverse events of testosterone replacement therapy. Unfortunately, the press, the lawyers, and the FDA got a hold of the first two studies, which demonstrated an increase in hazards. So I'm going to try to tell you and show you that testosterone was not only not harmful, but probably beneficial in normalizing in the average healthy man. So the problem with these studies were that the study populations were heterogeneous, intervention duration and study designs were all different. They had variable definitions of hypogonadism. They had variable ascertainments of cardiovascular outcomes. The treatment indications and indeed the treatment itself was unclear. In fact, there was none of these studies actually knew whether the patients took the medication or not. They knew that they got prescriptions, but none of them actually confirmed that either they'd taken the medication or that their testosterone had been normalized. So it really is kind of garbage in, garbage out. The study groups differed in baseline cardiovascular risk factors, so some of them had heart disease to begin with, some didn't. And really the findings were inconsistent across the studies, and really I think we would all agree if we review these studies that it's very difficult to draw any major conclusions. So let's start with endogenous testosterone, and this is a busy slide, but I'll just tell you a few things about it. Men with heart disease have significantly lower testosterone, free testosterone and bioavailable testosterone. Low endogenous testosterone is associated with, in many studies, with cardiovascular disease mortality. The correlation of testosterone levels, erectile dysfunction, and conditions are associated with cardiovascular risk. Men with coronary heart disease under the age of 45 had total free testosterone significantly lower than controls. So basically, all of these things show that if a man has low endogenous testosterone, his risk of cardiovascular disease is significantly higher than a man with normal testosterone. And this basically is a meta-analysis by Araujo and colleagues published in 2011, which demonstrates that fact that if you look at all the studies that are available for this particular issue, that is endogenous testosterone, you can see that the overall risk is significantly higher for cardiovascular events. This is the Shore study demonstrating that patients with low testosterone were associated with increased mortality. She divided the testosterone levels into low, equivocal, and normal, and you can see that the patients with normal testosterone levels were more likely to survive, more likely to have a longer life than the patients with obvious low testosterone levels at a highly statistically significant rate. Androgen deprivation therapy and the risk of diabetes. So the patients that we place on androgen deprivation therapy for prostate cancer, again, these patients are artificially low in their testosterone, but their risk of cardiovascular disease, diabetes, myocardial infarction, stroke, and sudden cardiac death are substantially higher than normal, and the adjusted hazard ratios are quite significant. So endogenous or created low testosterones are a significant problem. This is again from the Mayo Clinic proceedings, suggesting that GnRH agonist therapy for prostate cancer is associated with atheromatous plaque instability. So that may be one of the causes, or it may be the primary cause of cardiovascular risk in those patients that we're treating with androgen deprivation for carcinoma of the prostate. What about treated versus untreated patients? Well, another study by Molly Shores, again, these are American veterans, and you can see the difference between those patients treated with testosterone replacement therapy and those patients not treated with testosterone replacement therapy, looking at their overall mortality with a highly statistically significant improvement in mortality at 48 months for those patients treated with testosterone replacement therapy in this particular study. Another meta-analysis that looked at testosterone replacement therapy and associated cardiovascular disease, major adverse cardiac events, which is MACE, or cardiac-associated deaths, again shows that those patients with low testosterone are more likely to be at risk for difficulties with cardiac events. The T trials, which are probably the best testosterone trials to date that are published in the literature, are double-blind, placebo-controlled trials of testosterone, treated with patients for a full year or more and followed for a variety of different endpoints. And one of the endpoints was cardiovascular, so the cardiovascular trial is what's on the left. And what they saw was that testosterone was associated with an increase in non-calcified coronary artery plaque volume, but not calcified coronary artery calcium scores. What does that mean? Well, the conclusion of the group was that they didn't know, and there's going to be more follow-up to look at that particular issue of a change in coronary artery plaques that were not calcified in those patients that took testosterone. But if you look on the right side and you look at placebo versus testosterone, you can see that in the cardiovascular events, specifically myocardial infarction, stroke, cardiovascular death, and the total cardiovascular or MACE events were equivalent in both the placebo and the testosterone group showing that in this trial, which was an excellent trial, a really very good trial, there was no signal to cardiovascular adverse events in those patients with testosterone replacement therapy. This is the non-calcified coronary artery plaque that adds some concern to this discussion, but clearly we don't know the answer as to whether this is truly bad or not bad, and what the outcomes are based on these non-calcified coronary artery plaques and what their stability might be. So basically, this is an extremely busy slide that I'll just skip over in the interest of time. But the American Association of Clinical Endocrinologists suggests that patients that have low testosterone and symptoms and are not frail elderly should be considered for therapy for their low testosterone without significant concern for cardiovascular events in the otherwise healthy male with no significant cardiac history. So in conclusion, testosterone replacement therapy is well accepted in men with classical signs and symptoms of hypogonadism. Select chronic diseases and medications result in suppression of the HPG axis, especially those patients with opiates, those patients on therapy for prostate cancer, and may lead to significant problems with low testosterone and cardiovascular disease. Poorly defined mild reductions from chronic disease and aging should be risk-benefit associated. So if a patient has low testosterone and only mild symptoms or no symptoms, treatment is probably not appropriate. So with that, I will conclude, and thank you very much, and I'll now pass the baton to Dr. Mike Kirby.
Thank you, Callie. The next slide. So I'm talking about men, lifestyle, and the metabolic syndrome. These are my disclosures. I'm basically a tart. I work with anybody. It makes things better for my patients. So what is the metabolic syndrome? Well, it focuses on waist circumference. And this is the European definition, and this gives us a waist circumference of more than 94 centimeters for men and 80 centimeters for women, plus any two of the following: elevated triglycerides, a reduced HDL cholesterol, raised blood pressure, or a raised fasting plasma glucose. And in fact, having the metabolic syndrome is a very bad idea. If you look at morbidity and mortality in men without the metabolic syndrome, then I'll show you what happens when they develop the metabolic syndrome. You have increased coronary heart disease, infarctions, strokes, total mortality, and cardiovascular mortality all go up. It's a bad idea. Now, this study published in The Lancet gives us a clue about the importance of lifestyle in staying healthy. If you see here the leading causes of premature death and disability in England as the percentage of disability-adjusted life years, dietary risk is at the top. Tobacco smoke, high body mass index, blood pressure, alcohol, fasting plasma glucose, cholesterol, renal function, and low physical activity, which takes us back to where Roger started from, doesn't it? Lifestyle is critically important. Unfortunately, when we look at the league of obesity, looking at the percentage of the population older than 15 with a BMI index greater than 30, we are third in the world. All our European partners are right down the bottom end, with France at 9%, Italy 9%. We're third. Sorry about that, Callie. You're top. Now, this is important, really, because in The Lancet, they showed quite clearly that being overweight and obesity are linked to 10 common cancers and over 12,000 cases every year in the UK. The bottom line is that BMI was associated with 17 out of the 22 specific types of cancer examined. Now, visceral fat, we need to remember, is an active endocrine organ. Once you become fat in your abdomen, you become insulin resistant. So insulin levels go up. When people have pre-diabetes, they don't have low levels of insulin, they have high levels of insulin, and as a result of that, increased levels of IGF, which is a growth factor. Callie has already alluded to the fact that interleukin-6, TNF-alpha,
and leptin switch off the pituitary and the production of luteinizing hormone, which reduces the testis production of testosterone. And aromatization of testosterone in abdominal fat increased levels of estrogen. It's an unhealthy thing to have, isn't it? Now we know that prostate growth is driven both by DHT and IGF. And these patients with metabolic syndrome have high levels of IGF. And in fact, insulin levels have been shown to be a positive independent predictor of prostate enlargement. If we look at the components of the metabolic syndrome, the more components you have, then the more likely you are to have a low testosterone. So it increased the risk of having testosterone deficiency by about tenfold if you have 4 or 5 components of the metabolic syndrome. Then a low testosterone, of course, then drives more metabolic syndrome. On the other hand, physical activity may reduce cancer risk, and this was published in the BMJ. There was a lower risk of 13 types of cancer, and this study included more than 1 million people. And although adjusting for BMI modestly reduced the association, there was a clear link between 10 cancers significantly associated with reduced physical activity level. Meta-analysis studies involving 43,000 men found that exercise intensity was related to the reduction of prostate enlargement, and the risk of BPH or lower urinary tract symptoms was significantly reduced for men engaging in light, moderate, and physical activity versus the sedentary group. But what about obesity and benign prostate enlargement? Meta-analysis of previous studies suggested that obesity was associated with a 28% increased risk of BPH. And the health professionals' follow-up study included 18,000 men without LUTs at baseline. Those with a higher total and abdominal obesity were more likely to develop LUTs or suffer from progressive LUTs. In the Rancho Bernardo cohort, a 4-fold increase in the risk of BPH was found in men with diabetes with the LDL cholesterol in the highest tertile. Conversely, HDL cholesterol was lower and LDL higher in subjects with symptomatic BPH versus controls, and there we have the metabolic syndrome. A low HDL cholesterol is important. It's a negative independent predictor of prostate enlargement. What about cholesterol? In subjects with BPH, the addition of statin therapy has been shown to increase prostate volume reduction by 15-fold. So what is this relationship between lower urinary tract symptoms and the metabolic syndrome? Because we've demonstrated there are interconnected physiological, biochemical, clinical, and metabolic factors directly increase the risk of cardiovascular disease, type 2 diabetes, and all-cause mortality. And I've already defined what the metabolic syndrome actually is. But the presence of metabolic syndrome and the number of metabolic syndrome components is related to LUTs and BPH severity. And men with BPH are more likely to have the metabolic syndrome than men without BPH. This is a study that we published in the BJUI, showing quite clearly, this was a database study taken from primary care general practices, that men with BPH are more likely to have the metabolic syndrome, and each component of the metabolic syndrome compared to their matched controls without BPH. And that was true for both lifetime and the current definition of metabolic syndrome. Now we know LUTs and ED are often coexisting. And in fact, in men who are seeking treatment, about 78% of them will have both conditions. And the reason for that is there are pathophysiological pathways that lead to both LUTs and ED in men, with preclinical evidence the metabolic syndrome is associated with insulin resistance, which activates the sympathetic nervous system, and there's an increase in prostate smooth muscle tone. Cully's told you about the hormone changes we see with increased estradiol and a lower testosterone. The risk factors cause pelvic atherosclerosis. There's bladder and prostate ischemia and ischemia of the corpora cavernosum, and inflammation by the cytokine release from the abdominal fat. All of this leads to ED, LUTS, BPH, and BPE. So what do you need to consider if your patient is presenting with symptoms of ED or BPH? If they have one, we should be asking about the other. We should be asking about sexual and urinary health. And think about doing the HbA1c. Could this man have prediabetes, hyperlipidemia, raised blood pressure? What is the waist circumference? Has he a raised PSA? And what is the testosterone level? Lifestyle can improve both ED and BPH. I've already demonstrated that it should be a first-line intervention and has significant benefits leading to a reduced risk of cardiovascular disease and diabetes, improved erectile function, improved lower urinary tract symptoms, and testosterone levels. We need to encourage our patients to alter their weight, lose weight, increase physical activity, stop smoking, be moderate with alcohol, and manage stress. So as physicians and surgeons, we need to monitor and manage these reversible risk factors that I demonstrated early on in the presentation. We should not miss the opportunity to emphasize the importance of a healthy diet, physical activity, and smoking cessation, and sexual counseling, of course. But PDE5 inhibitors have an important part to play, both in managing the LUTS and the ED. We need to deliver this message at every contact in a sincere way, which is non-judgmental. We need to move our patients from contemplation to action, because on the whole, they know what they should be doing. Mark Twain said, "You can't throw a habit out of the window. You have to coax it downstairs one step at a time," and I'm not saying it's easy. There are two, I think, very important studies about PDE5 inhibitors, and I think we miss a trick if we don't use them in our patients with ED and lower urinary tract symptoms. The study on the left we published in Heart. It was a GP database study where we looked at men with diabetes and compared those who'd ever taken a PDE5 inhibitor with those who'd never had. Over 7.5 years, there was a 31% less risk of all-cause mortality in those men who were being treated with PDE5 inhibitors. A couple of months later, in the same journal, a Swedish research group had done something very similar, but they did it with patients who had cardiac disease and had a heart attack. They asked the same question: have you ever taken a PDE5 inhibitor? Amazingly, they found exactly the same benefit from taking these drugs, a 38% less risk of all-cause mortality over a mean of 3.3 years in men taking a PDE5 inhibitor. This was not the case in men using injection therapy to manage their ED. So keep this in your consulting rooms. When you see these men, it gives you an opportunity to talk about diet, but also exercise. You'll see at the bottom, these men should be exercising twice a day. 20 minutes of exercise increases your insulin sensitivity for 15 hours. It's important. Lots of fresh fruit, vegetables, salads, and fish. Keep away from too much in the way of dairy products, red meat, and sweets. It's a simple message, can be delivered very quickly, and I get them to stick this on the front of their fridge. When you open your fridge, this is what it should look like. It saves lives. This is a Spanish study, and they see here we compare a control diet, which is a typical low-fat diet, with a Mediterranean diet. You reduce the risk of a myocardial infarction by about 30%, and you reduce mortality by about 25% over a 5-year period. And those curves seem to split quite early. Mediterranean diet versus low-fat diet. At the end of the day, if the patient won't listen to what you suggest, I suggest you try this. What fits your busy schedule better? Exercising for an hour a day or being dead 24 hours of the day? The bottom line is we need a more precise patient profile. Think, when we see our patients, what is actually going on within them in terms of metabolic syndrome. At the end of the day, we all need a true friend, don't we? The only person I would do this for is my brother, and I have. It may not be a drug. And there, Mr. Chairman, I rest my case, and I'd like to introduce the next speaker, Dr. Rupal, please.
Good afternoon. Thank you very much for the invitation. So I'm going to now turn the story a little bit towards lung cancer. So just to really highlight why is lung cancer important and why so particularly in men, well, it's the second most common cancer and it's the biggest cause of cancer mortality in men in the UK. And 97 people, and mostly this is more men than women, die every single day from lung cancer. Lung cancer survival at 1 year is pretty poor at 30%, and it falls dramatically down to 8% and 4% at 5 and 10 years. So why is this? So people who are diagnosed with stage 3 or stage 4 lung cancer typically are inoperable, and therefore options for treatment are limited. This is rapidly improving just over the last year. We've got some really fantastic new treatments available, but really the number of people qualifying for these treatments is still low. And the main thing that we can do at the moment is to improve our rates of early detection. And certainly at the moment, about 70% of patients are being diagnosed at stages 3 and 4 and inoperable, and therefore outcomes are still very poor. So what about screening? It's not a novel idea. Why have we not thought about this before? Lots of trials were done, starting as early as sort of the 70s, looking at sputum cytology and chest x-ray, but none found any mortality benefit. Thanks to advances in CT processing with a dramatic reduction in radiation dose, this was a new era for lung cancer screening, and that low-dose CT came into play. And actually, today we have ultra-low-dose CT, which is a fraction. It's about half a millisievert in terms of each scan. The sensitivity for picking up lung cancers is much higher, and we can pick up really small, early-stage lesions. Of course, with this comes the problem of indeterminate pulmonary nodules, and that's a separate issue that we have to deal with, prepare for, so that we can reduce harms from that as well. So everything really changed for lung cancer screening in 2011, and this big study, which was in just over 50,000 participants, and what they did is they screened, the intervention arm had low-dose CT every year for 3 years, and the control arm had a chest x-ray every year for 3 years. And it was just for 3 years, and they followed patients up for a further 7 years. And the trial at that point was stopped because they had reported an outstanding reduction in lung cancer-specific mortality and even in all-cause mortality, something that we haven't really seen in other screening modalities. And a study in the UK lung cancer screening study, found that this is an extremely cost-effective intervention, much, much more so perhaps even than breast cancer screening, with a cost per qualia of about 8,000 to 9,000, so a third of what's really required by NICE. So where are we with lung cancer screening? Well, in the US, they're doing it. They're doing it for high-risk smokers, so that's neglected to mention, but that's who were included in the National Lung Screening Trial. And typically they recommend it for people aged 55 to 80, although Medicare and Medicaid are now funding it for those aged 55 to 77. And they crucially have to have quite a high smoking exposure. Where are we in the UK? Well, as I mentioned, there was the UK lung cancer screening study, which took place across 2 sites, and there were several small-scale pilots since then, one of which I've been working on down in London. A more new study has been started in Leeds, which is aiming to scan about 7,000 people, and now £70 million have been invested into the NHS England pilots across these sites, meant to be taking place in areas of unmet need where lung cancer prevalence is particularly high. But the National Screening Committee, at the moment, as you can see, this page looks like it should have been updated a couple of years ago, and we're still waiting on it. And this is mainly because the National Lung Screening Trial that I presented at the beginning of the presentation was a big study in the US, and it was a very well-conducted study, but it was a single randomized control study to date that has been shown to prove a mortality benefit. So the Nelson study is a Dutch-Belgian study, a much smaller study, much less powered to detect a mortality benefit, and up until very recently we were waiting for the results. We're still waiting for the full manuscript, but there is a significant improvement in lung cancer specific mortality that has also been corroborated in this study, and I'll come on to that. But the National Screening Committee in the UK, as we understand it, are still waiting for the full manuscript to be published, and hopefully we can await a decision on it, and maybe we'll be seeing it more widely in the UK. Well, are there lots of different challenges? So I've just touched on the political issues with NSC buy-in, and obviously these things cost money. It's cost effective, but obviously in this particular climate within the NHS, funding is obviously a bit of an issue that needs to be overcome. There are other issues. We've been recently embarking on a larger project, and infrastructure is crucial. The IT, the service demands, the number of lung cancer resections, etc., that are going to be necessary, as well as making sure that QA and governance are robust, and also software such as volumetry is available widely. And then there are research topics that we need to probably understand a bit better. And again, all of these pilot studies that are going on are helping us to understand much more about how we can improve these things. So integrating smoking cessation is really, really crucial. And we heard a little bit about that, how to manage incidental findings and these pulmonary nodules, and improving equitable uptake. Sorry, I can't speak. Also about balancing harms, so overdiagnosis and radiation, probably not too much of an issue overall, but still things to be considered. It's important that our patients have the options to make an informed, and the tools to make an informed decision, and obviously trying to reduce the benefits and harms by optimizing the screening intervals. So just to bring it back to men a little bit more, we did some qualitative work looking at the different screening programs and what people thought about them, and we were then obviously asking more about lung cancer screening. But interestingly, one male participant said men ignore things more than women. We've heard that earlier today as well. And then other than bowel screening, that's all that men get, isn't it really? So, you know, at the moment, there are breast and cervical cancer screening options available for women, but really not a great deal for men. So lung cancer screening is an amazing opportunity for that in terms of improving men's health. So just to bring it back to equitable uptake, so we know that those who are highest risk for lung cancer, so those who are from more socioeconomically deprived communities and those who are typically current smokers, are least likely to attend screening, and particularly sort of lung cancer screening. And this is Dr. Sami Quaife, who's a psychologist that we've been working with. So we did something called the Lung Screen Uptake Trial, where we tested out, so the picture in the middle is sort of a screen grab from the invitation leaflet, which is aimed to try and improve uptake to lung cancer screening by reducing scary messages like about cancer and about smoking, reducing stigma, and also to be more palatable and less frightening, compared with a really well-written leaflet, which is more in line with other NHS literature. And we're still analysing these results, but through doing this, we've been able to screen about 770 people and have brought about a massive stage shift in lung cancer. And this is similar to results that we've been seeing around the country with other pilots. So as you can see, the dark blue bars are our much more increased stage 1 diagnosis compared with the national averages. And our resection rates have increased from about 18.4% nationally to 75%. And even with small cell, we had 100%, which is small cell lung cancer is very unusual to be detected at an early stage, and we've managed to give everybody chemotherapy. So some really promising results from this. And then this is Professor Sam James, who's was my main boss, and he's been leading the sort of spin-off study to this, which is an immense 25,000 participants. It's going to be one of the largest lung cancer screening studies worldwide. And it's now underway. We've screened, I think, almost up to the first 1,000. And again, we're going to be looking at lots of different outcomes and looking at biomarkers in terms of how we can try and improve lung cancer diagnosis. So this is the Nelson study, and I was talking about the abstract that was presented at the World Lung Cancer Congress in 2018. And you can see here, quite interestingly, that there's a significant relative reduction in men. Interestingly, in this study, about 84% of the participants were men. So you can see that the confidence intervals here for the relative reduction in women is actually quite wide. And that's mainly because the sample size was quite small. But here you see a signal that perhaps women might be benefiting from lung cancer screening more than men, which is quite an odd finding, and I don't think we fully understand the reasons why. But interestingly, looking at NLST, the American study I presented at the beginning, a similar signal was seen here. So do take the figures here in terms of the cost per quality with a pinch of salt. This is American figures where things are a little bit more expensive, but you can see that women were 3 times more cost effective to screen than men. And again, we're not really sure why, whether this is due to tumor biology, whether it's to do with increased life expectancy, lots of unmeasured factors such as diet and exercise and all these other things. And it's something that I think clearly needs to be looked into in more detail, but is quite an interesting finding. And I wonder whether part of it is related to bringing it back to the earlier talks, but cardiovascular disease, for example. So we know that ischemic heart disease and stroke and also other respiratory diseases are within the top 3 causes of death worldwide. And we know from the NLST data that in the screened arm, in the low-dose CT arm, where they reduced the deaths from lung cancer, cardiovascular disease became the most common cause of death. And this isn't surprising because obviously smoking and age are the risk factors for all of these conditions together. And we know that men are much more likely to have coronary heart disease and more likely to have stroke than women. So perhaps this is something that we can exploit further with lung cancer screening. And we heard earlier about coronary calcium scores, and I didn't include a slide on this just for the interest of time, but low-dose CT scans in lung cancer screening context can also pick up coronary calcium and can be a real motivator perhaps when we feed these results back to patients to tell them, well, look, you've got calcium on your scan, and actually this is another reason to stop smoking or another reason to address your high blood pressure and cholesterol and so on. And in fact, within our lung screen uptake trial cohort, we found that 98% of participants, before they even had their scan, already met the Q risk, the criteria for having statins as primary prevention, and yet only half were actually taking them. So there is here a huge opportunity through lung cancer screening to address these other comorbidities that affect the health of men and women. So just to conclude, lung cancer is an important cause of mortality, and there really is an urgent need to improve outcomes. We've got 2 now big studies that have provided clear evidence, and actually a third one from Europe that I didn't talk about as well, from Italy, that really confirmed that it does work to reduce lung cancer death. There's lots of important and exciting projects underway around the UK, and will help us to really address all the other issues that are outstanding, and hopefully we'll be able to have a national rollout at some time in the future. Women might stand to gain more benefit from lung cancer screening, but perhaps by addressing some of the other issues, we can make a greater impact on men's health also. Thank you very much for listening, and thank you also to my mentors and supervisors.
Well, great. That was all our speakers kept brilliantly to time, so we've got a few minutes for discussion. So I'd really like some feedback from the audience about whether you think the message that urologists should be men's health doctors in the same way that gynecologists are women's health doctors. And if you think about the different emphasis on women's health, where every GP practice will have a women's health specialist component, compared with really the lack of interest in men's health, it's a political issue as well as a medical issue. And I guess thinking about the D words from my slide about the Ds, the D word for men's health is really deprivation, because nearly all these problems, smoking, alcohol, risk-taking, HIV, etc., is very strongly correlated with deprivation and more common in deprived areas. So, any comments from the audience? We have some microphones. Parokar Dasgupta, prostate surgeon extraordinaire, editor of the BJUI, and nice person. Parokar.
Talking about nice, Roger, of course a nice person, but the NICE guidelines on prostate cancer 2019, just published in the BJUI, make no mention of screening. The EAU, of course, does not recommend screening. How can a urologist avoid the prostate cancer issue and talk to men about lung cancer, bowel cancer, and heart disease instead?
Let's ask Cully to answer that. It's a bit of a tricky question. May as well pass the buck.
That's a tough one because I know nothing about NICE, so I know nothing. In the U.S., it's changed. So the guidelines in the U.S. were initially that no men should get PSA, and if there was a decision to do a PSA on men, it should be discussed. That's kind of paraphrasing the guidelines, but they've since changed that, and now the guidelines are that men over the age of 50 should get PSAs, assuming that they are willing to do that, and if they have high risk factors for prostate cancer, a family member, et cetera, African American, then even more emphasis is placed on doing PSA. So the pendulum has swung in the U.S. to some extent. It hasn't come back to widespread screening yet, but it's come back to at least, I think, a reasonable way of approaching PSA and prostate cancer.
Prokar, the National Screening Committee are doing an evidence review on prostate cancer screening. And the Prostate Cancer Risk Management Program says quite clearly that any man who wants to know his PSA is entitled to know it. Again, it's one of the things where perhaps men need to know their numbers. I think it's really interesting that perhaps it's more important the younger men, because you know the PSA between 40 and 50, but if your PSA is over 1 when you're 40, then you have a 19-fold increase in the risk of prostate cancer in future years. And it may be that doing it before people get BPH gives us a much more useful figure for predicting future prostate cancer, and also advising people how often they should have their PSA done. Because if you've got a PSA less than 0.6 when you're 40 to 50, you probably don't need to have a PSA done for many years ahead.
Let's ask Mamta a question, because she's come all the way up from UCL to talk to us about lung cancer. Mamta, I guess from urologist's point of view, is what should we say to our patients who smoke? How do we persuade them to quit?
I think it's a real challenge, isn't it? I think in the respiratory clinic we find it a real challenge, and these are people with direct symptoms often from their smoking, and yet often tobacco dependence is the kind of thing that makes it very difficult for people to actually want to stop. But I think there's some useful guidance, and there's in fact a very brief advice training module that people can do very easily, which talks about asking, advising, and arranging follow-up in terms of smoking cessation, letting them know that behavioural support and drug support really work well together. I think varenicline is really, really useful as well. And ultimately, I think letting them know that quitting is a journey. Many people quit several times before they're successful. And I think just the more health professionals that keep pushing that message, eventually they will at least begin to get through, hopefully.
Should we tell them to vape instead of smoke?
I think the current advice on that is probably yes, in terms of harm reduction. We obviously don't know all the harms associated with vaping, but we think it's the lesser of the two evils. And I think it is a really useful way for many people to stop.
Well, in the audience, we've got the one and only professor of men's health in the UK. You're a very rare species, endangered species, actually. Professor Alan White, any thoughts, comments, questions?
Yeah, very impressive conversation. But what was going through my mind as one of the baby boomers, 59 I was born, and my chance of growing up to be old and then very old is a new challenge for you. How do you see 1 in 4 of us being over 65 by 2040? How do you see the 90-year-olds, the 100-year-olds that you're going to come through your clinics as new challenges to you?
Well, maybe Cully, Mike, any thoughts? I mean, we are seeing, is it centenarians, people who are older than 100 quite often these days?
Well, the secret is staying fit throughout your life, really. We know, certainly from the testosterone studies, that 75% of men retain normal testosterone levels right through their lifetime. as long as they don't collect comorbidities, and particularly cardiovascular risk factors, metabolic syndrome. So I think the key is to have a healthy diet and exercise right throughout your life. And if you take one message away from me today, is you need to get out there and do some exercise twice a day. Make sure you've got your step counters, do your 10,000 steps. And it's really good evidence that staying physically active and eating a healthy Mediterranean-style diet will reduce a lot of the comorbidities that we're trying to deal with in people in their 80s and 90s.
There's a great jogging track down by the Clyde, actually, so we'd like to see everybody in the audience with their running clothes on tomorrow. We've got 6 seconds before we finish, so I'm going to leave you with the last word: binge responsibly. That's my message, personal message to urologists worldwide. Thank you, everybody.
You're right about chronic calcium scoring.